Matt Bonds is a associate professor of global health and social medicine at Harvard Medical School, and he is the co-founder of Pivot, which is an NGO that works with the Madagascar government to establish a district-level model health system. Matt, thank you so much for taking the time to talk to me today.
Thank you.
So to start, I'd love to hear more about this program, Pivot, and how it started.
Um, well, thanks, Joe. Thanks for having me. Happy to talk about Pivot anytime, of course. So Pivot is as you mentioned, a health NGO. It's it it partners with the Ministry of Health of Madagascar, works in a population now of about 1 million people, and it prioritizes this health system strengthening. We work across the entire local health system, community health workers, primary care centers, hospitals, the full range of what's involved in health system strengthening. So that's human resource, recruitment and training, infrastructure, removing financial barriers. Um, and we specialize on data and analytics and try to um, advance the science of healthcare delivery. And broadly, what I would say is we're particularly um, good at the relationship between medical and global health delivery and population health. So a lot of the way we look at things largely is not just from the perspective of individual patients and caregivers, but also of the population at large. So we track really closely population health indicators like under five mortality, maternal mortality, infant mortality, access to care, which we call coverage. So the success is measured not just in terms of patient care, but who becomes patients and who is not a patient in the population at large.
Yeah, so I'd love to hear more about how you kind of define the system and specifically like the components that go into that, and how do you set that up at a country level? I think um, you mentioned it's a district level model. What does it mean to be a district level model health system, and how does that come together?
Right. So one thing that's worth noting is that actually for any system, it matters a lot that the system itself is defined, that it has like boundaries of some kind. And we think about this in the way that scientists think about systems, and which we think it hopefully offers some insights into how to solve problems that have been otherwise pretty thorny because breakdowns happen at a systems level. So a child might not get health care. Um, Not just because they might not have financial resources. It might be because there's a supply chain breakdown. It might be because there's a human resource issue that someone wasn't available to treat them at the right point of care at the time of the point of care. So there is a system that ultimately determines whether a person gets sick and whether they get care. And in this case, we define the system at the district level, and that's like a natural unit of organization, probably the most important unit of organization that the healthcare system of Madagascar operates. And that's similar to most other sub-Saharan African countries. So every district in Madagascar has one district hospital that serves the population. There'll be a district health officer that is ultimately in charge of all of the primary care health centers in that district. Every district will have many primary care health centers. Each primary care health center is supposed to have certain characteristics. There's supposed to be a medical doctor, for example. There's supposed to be a nurse, a midwife, things like that. And then in the primary care health centers are distributed geographically across municipalities, and then within them, the head of each community, each primary care health center, the head of that health center is ultimately supervising and in charge of all the community health workers that operate the village level. So you have a hierarchical system from the community level to the primary care level to the district level. And that is a very useful way of organizing the health system. It goes higher, like there's something called a region, which is multiple districts, and all of those are relevant. But if you're thinking about how supplies come into it, to how all the needs and inputs that ultimately reach a patient, it goes through a district health system. And so that's what the level we're working in.
So within those different levels that you described, I assume there are different levels of capability. You described a point of care, like for screening. I assume you can do that at the village level, and then as you work up to different um, levels of care or needs for diagnosis, that goes up to the district level hospitals that you described. Is
Yeah.
that accurate?
That's right. The general trajectory is this, it goes as the situations get more complicated, it tends to go up the system. I mean, it's highly regulated, so this is not again, this is not just true for Madagascar. These are broadly informed by World Health Organization guidelines. Ministries across Africa are highly aligned at what levels of service should be, what quality of services should be provided at what level of the healthcare system. So, community health workers have a very specific protocol that are fairly uniform across the continent, actually, and so they do a lot of child health, children for treatment of diagnosis and treatment of malaria, especially for children under 5, treatment for diarrhea and pneumonia. And then screening can happen at the community level, screening for malnutrition, screening for symptoms of tuberculosis. Um, and then there's reproductive health services that happen at the community level. And at the next level, at the level of the healthcare center, then you get your normal forms of primary care. So most of the maternal health services happen at the primary care center. So antenatal care, deliveries, postnatal care, vaccines are mostly distributed at the primary care level. Most ordinary emergencies, not just ordinary accidents of various kinds, infectious diseases of various kinds, people will tend to go to the primary care center first, and then it's only if they're referred to the hospital that will they go to the hospital. Usually it comes from a referral first, and those are basically cases that are too difficult for the health center to be able to manage. So that could be complicated cases of malaria, it could be complicated cases of malnutrition, it can be complications with pregnancy, it could be tuberculosis, etc.
So you mentioned one of the primary outcomes that you focus on is the mortality rates of children under 5. How is that? What's the trend look like there, and how has that developed over time, both in Madagascar and globally?
Yeah. That's a you're probably not aware that that's like a hot button issue. Like that was fire, what you just said. Like that's an electric thing to say. I'm almost semi kidding. So under 5 mortality is genuinely a controversial topic, and it's controversial mainly because it's been very hard generally to demonstrate that field-based organizations or efforts, initiatives that are happening locally, it's been very hard to demonstrate changes at the population level, mortality changes at the population level, which is very unintuitive. So the real tension there is that the global health community, the way that international funding gets allocated, the way that guidelines get set, those are oriented around development targets, health development targets. So countries have goals around maternal mortality, under 5 mortality, infant mortality, and which is good, measure general progress. They have lots of other goals around healthcare coverage and universal health coverage, et cetera. But to demonstrate that a package of initiatives can reach those goals, that's actually very difficult. Um, and by and large, the efforts that have been made to demonstrate that have mostly shown kind of inconclusive results. So we are this is, by the way, a real tough issue for science, and I sometimes say there's a dilemma, which is that there's an abundant evidence that individual health interventions should save lives, and there's like almost no evidence that integrated health services save lives. Why would that happen? And the solution to that paradox is that we do studies, we do randomized trials. That's how we know the efficacy of something, right? Like we test vaccines and other kinds of interventions. We test deliveries of healthcare and antenatal care programs. We know that interventions that in a highly controlled study will show that people who receive the intervention survive longer than people who don't, right? So that's the nature of medical science. But when you actually implement those programs in the real world under real world contexts, right, where they're difficult to roll out, where the study design might be different than the practical realities, um, uh, and where people are cause of mortality are abundant from lots of different sources, right? So, a malnourished child might also get sick from something else. So, so the reality is that's actually really hard to demonstrate that in a real world context, not a highly controlled research study, that the programs that we have, medical programs, result in low mortalities. Our evidence is actually really good. Where our latest work is like in review now, but the basic results are that under 5 mortality has dropped about 31% over the last 10 years. Infant mortality has dropped significantly more than, well, about 25%, but about 40% less lower than the comparison areas. And actually, even maternal mortality has dropped by about 50%, um, which if someone who's watching this is informed, they would appropriately be suspicious of like claims like that, because in the past, when studies have claimed such results, they tend to be very dubious, right? For example, there's a lot of studies out there that will show results um, of changes in mortality rates that look pretty good, but in fact they tend to be less or equal to national trends. That's a pretty common way that people publish results in mortality. Unfortunately, they say, "Oh, look, we've seen a 6% annual decrease in mortality, in child mortality," where like the national trends are seeing show the same thing. So in our case, what's sadly unique about Madagascar is, unfortunately, uh, it's under 5 mortality has not been dropping for the last 10 years. In fact, it's slightly going up. Under 5 mortality is not going down. Infant mortality has not been going down. Um, and so it's a context in which it's struggling to make progress on its core goals. It's not making progress on some of its core health goals. And we collect data in an intervention area and also collect data outside an intervention, a comparison area. And so this evidence is pretty strong by comparison.
So just a point of clarification, you mentioned individual versus integrated health. That's is it the individual is like the very specific intervention around a specific disease, and then the integrated health is a more broad systems level view of an implementation of a program. Is that an accurate way to
Yeah,
think about those two concepts?
yeah, yeah. I mean, right. So that the evidence that a particular intervention, a medical intervention, saves lives is like overwhelming. That if you're a physician and a child has a malaria and is on a fatal path of malaria, right? You can give that child, he or she, malaria treatment, and they will almost always recover,
Hmm.
right? So physician, it strains credibility to question whether these cases in the real world are effective. Also, lots of randomized trials that show, vaccines work, malaria treatment works, antibiotics work, oral rehydration therapy works. So they know, physicians know that, and then randomized control trials demonstrate that. So then the question is why, when programs actually roll out these, right, roll out these services. So we do lots of integrated child and maternal health interventions. We support supply chains. We train. We recruit with the Madagascar Ministry of Health, community health workers and primary care providers. We support the training of them. We build infrastructure. Uh, we've literally directly supported almost 2 million patients in a founding district. And when you do something like that, you would think, oh, obviously, this is over 10 years, but you're going to see reductions in mortality because we know treatment rates for fatal illness has gone up. But generally speaking, it's been very hard to show that. And the reason so that's the question is why? Like, why is it that when these services are being provided, you're not seeing a very clear signal at the population level? I mean, there's three, I'll just quickly summarize. There's three reasons why why that could be. One could be a legitimate limitation of medicine. It's like not as good, it's not as important as you think. Like broadly speaking, there's an argument for saying for health outcomes are social and environmentally determined. The context matters a lot. That medicine's a band-aid, and it can't fix all the problems, right? That's like so one's a limit. One argument is the limitations of medicine in isolation, yes, but broadly speaking, all-cause mortality reductions from interventions may or may not happen. So one is it question limitations of medicine. Um, Another really common explanation, popular explanation, maybe even more common, is a limitation of programs. So this is the argument that aid doesn't work, right? Programs get funded, on paper they exist, but if you look actually what happens, like the services don't find their way to patients very well. I'm not saying this is happening. I'm saying this is an explanation, right? And so we call that fidelity, right? The programs don't happen the way we think they happen. And the third issue is the science. So these are really hard things to measure. For example, under five mortality. To measure under five mortality, you take a 5-year birth history. You ask people how many children have they had the past 5 years, and you measure, and then how many are still alive, and you use that to then project what the under five mortality rate is. So it would take you at least 5 years to see the impact of a program that started now. Understand, so 5-year under five mortality is like a 5-year moving average. So that takes longer time series. You need more data, right? You need higher resolution data. Things are just noisy, and it's expensive to collect this kind of information. So, if you're collecting information on a few hundred households in a district, that's going to be a lot of noise, right? So, we collect information on a couple thousand households. That helps. So there's like noisy data, there's time series issues, and then there's like confounders, like other factors that are at place. Like you might not have a comparison area, or there might be services provided in your comparison area. So like so the reason why we've had trouble finding results on this topic of impacts on undefined mortality and other sources of mortality is limitations of medicine, limitations of programs, and limitations of science.
So how do you reconcile like I don't know what it'd be described as. In economics, it would be considered like a shock to the economy. But like in the last 10 years, we had a pandemic.
Yeah,
So infant mortality, if you were operating these past 10 years as the 10 previous years, you would think that if under normal times you would see the improvement, but then there was this pandemic. So does the
yeah,
data capture that, or are you able to you mentioned like noisy data and thinking about how you look at the numbers in different ways, but
yeah,
also the fact that you're collecting more data now, would that be a signal that you're kind of baselining at this point, or how do you think about those different kinds of
yeah.
ways of thinking about data?
So I'll start with that second question, and then I'll go to the first. So we are big believers. When I say we, I mean the overall program at Pivot. So there's a research team in addition to program staff, about 400 program staff. And we are believers in lots of different kinds of data, right? So one really core piece of data that we rely on is we took a true baseline. So data from households in the inner core area, intervention area, and the comparison area, about 7,000 individuals, and then we track them longitudinally over time, the same people. In the intervention area and comparison area. So that's really powerful data. So that's not patients. That's not about who comes into the health center. That's who's living in the area. And it's not, it doesn't get distorted by people moving into the area, right? For whatever reasons. And because there's a comparison in an intervention area, that should affect, roughly speaking, any major epidemic like the pandemic would affect both those areas equally, so you can see a relative effect from our intervention area. So that's what I would call like, and then on top of that, we collect a lot of information through the health system. So so we collect a lot of information in on individual patients. So we compile information to get a stronger understanding of who's getting care and who's not getting care, where people live who don't get care, how things like what we call geographic equity and financial equity are affected, and so the overall distribution of healthcare access over time in the intervention area and comparison areas. So those are, but still, so that said, like ideally you could get a grip on this, but the truth is, like I had an old mentor, Paul Farmer, who would say it's an epidemic every year. Like, we're dealing with, since we started, there's been a plague epidemic. There's been a major measles epidemic. Some of the biggest plague and measles epidemic of the last 50, 60 years happened in Madagascar. There's the COVID-19 pandemic. And then there's pandemics, there's epidemics of things that are totally undiagnosed. Those are only diseases that we're able to track well. But the fact is, like, this is another misunderstanding, I think, in these areas. Like, we've done through lots of data collection and lots of analysis. We estimate that about 1 in 5 children with malaria, even in our area where the average child is treated like twice as much now as they were 10 years ago, and there's like all these care being provided, and user fees are removed, even there, only 1 in 5 malaria cases actually reach someone who gives them a diagnosis and treatment. And this is despite the fact that community health workers have rapid detection tests for malaria and can treat remotely for malaria. So the prevalence of malaria is the incidence, I should say, is probably 5 times the real incidence is 5 times what we can detect, and that's just of malaria. And so then there's other illnesses that we're doing lots of kinds of analysis. There's potentially dengue fever that's happening and going undiagnosed, and other kinds of viruses that are similar to dengue fever. Chikungunya. There's just like a lot of the World Health Organization has these guidelines around treating diarrheal disease and respiratory infections, but diarrheal disease is like you could have 18 different causes of a diarrheal illness. It could be parasites, it could be bacteria, it could be viruses. You could have cholera. The point here is what you're saying is like, yeah, there's a lot happening, and there's a lot of causes of potential noise, and those things can be localized, and those are all the reasons why it's so difficult. Those are some of the explanations for why it's been difficult to detect, the impacts that people would like to detect.
So I want to step back for a second and ask about so you have your background is a PhD in disease ecology and a PhD in economics. And so I wanted to ask you about how you think about those two subject matter overlapping and deploying that overlapping thinking on these societal, like these global health problems. And then also thinking about what you're describing. I listened to a talk of you speaking at University of Waterloo where you were talking about virtuous and vicious cycles. And I wonder if there's kind of a unique perspective of someone with a both economics and ecological background and thinking about how you address um, global health issues, poverty, and those together.
Yeah, thanks.
Sorry, that was a lot of
No, no, it's
a
good.
lot
No,
of question in
no,
one.
no, but it's all coherent. I'll try to answer it. So yeah, my training is in economics, my training and ecology. When I was younger, I I was interested. My lens was, I thought my conscious lens was, oh, I'm interested in humans' interaction with the environment, right? And I'm interested in the fact that biophysical phenomena shape our lives in some way. And that was like the topic that was interesting to me. But then if you study economics and you study ecology, if what one would find is that economists think about economic systems in ways that it's very similar to how a lot of ecologists think about ecological systems, right? Like economists think about markets. They don't use this language, but they're describing markets as dynamic systems, right? They talk about equilibria, but equilibria is basically an emergent property of a dynamic system. That's like emergent property of dynamic systems, how complex systems theorists now talk about these things, right? And economists love to talk about unintended consequences when people misunderstand markets, but that's because systems are complex, right? Uh, So over time, I used to think, oh, I'm so interested in the fundamental properties that ecosystems and economies have together. And if you were to like similarly study like I don't know, predator-prey behavior or a niche, an ecological niche of an organism, it would look a lot like the way economists think about how, a firm might optimize itself in a market, in an environment, right? It's like trying to maximize something. It's like reproductive fitness or something, and given constraints of like resources. So there's a lot that ecologists think about. Is like, how did this state arise to generate these outcomes? And that's what economists think about. And over time, I started realizing, oh, it's not that I'm just interested in economies and in ecosystems. I'm interested in systems. And when you see something like um, extreme poverty or persistent disease in an environment, or for that matter, if you see something like a healthcare system that is not working, right? If you go to a primary care center in Madagascar, you might see nothing happening, like literally nothing happening. What that looks like, what you normally think is, oh, nothing's happening here. It lacks resources. That's what it's lacking. It's nothing's happening because it can't pay for stuff, right? I see it as oh, that's a state. It's not nothing. It's not the absence of things. It's actually the expression of a state, right? And that state, if that makes any sense, and that state is the result of lots of different things happening, right? It's geopolitical, right? It's environmental, like or at least geographic and ecological. It's social and cultural. It's like economic. There's a lot that goes on into why a system might be working in one way or it might not be working in another way, right? Why a system might become more complex and more functional over time, or why it might break down. So I sort of see like a healthcare system as in Ranamafana, the first time I was there, there's a primary care center that's right down the hill from a national park. And the national park is Ranamafana National Park, and it's a UNESCO World Heritage Site. It's got like 16 species of lemurs. It's like, it's special, right? It's a montane rainforest. You know, 90% of what you'll find in that forest you can't find anywhere else in the world. And when you're in a place like that, there's not a person who doesn't walk into a place like that and say, oh, this place is is complex. It's special. Like every entity that you see, every flower that's fertilized is the consequence of a cascade of a lot of other actors in the system at work, right? Every moment that something dies and decays and turns into soil, every source of water that comes off the Indian Ocean gets captured by the rain, goes into the soil, like turns into a river. There's like, everyone understands that, right? If you go from there, and it's beautiful, it's special, right? Like, and if you go from there and you go into a health center, and you, as I have done, and you find someone dying of like not getting health care, and it's like, oh, there's no electricity, there's mold, the all the walls are moldy, there's the pharmacy is barren, and someone sitting here with a treatable illness and is about to die. A kid is sitting is about to die. And what I see, the way that I experience that is that's a system that's not working, where the things didn't come together to ultimately land where the thing that she needs is a molecule. It's like treatment, right? And that treatment, that's sitting someplace. It's sitting in a pharmacy somewhere, maybe at the local level, maybe at the regional level, but it's cheap, right? It's like $3 for most malaria treatment. Something's breaking down. It's preventing that kid at the time that she needs it for that care to be available. It's not science. It's not a lack of understanding, etc. And I think understanding why is the state like the way it is. That's sort of how I think about it. If that makes sense.
Yeah, I'm that's super. I love just listening to you talk about this. So the state, just to further clarify it, like the state, the way you're talking about it is like the state of a union, the state of a state of mind, like it's a current state, future state type of thinking, right?
Right.
So the current state is, in these situations that you're describing, is it the result of a vicious cycle? Is it it's like something that can be quickly fixed? Is it something that is lacking a certain human resource? What are you seeing as like the causes of when the system breaks down or is not working or is in a current state that is not ideal? What are you seeing as the cause and what do you see as the solution?
Yeah, I mean, so what I see is so first, just to put it out there that it is the state emerges from a lot of different factors at work, and just acknowledging that as a starting point, saying it is not merely the lack of malaria. You could if you could drop a bunch of a year's supply of malaria drugs at that health center, um, eventually you would still see things break down, right? Like it's not simply the lack of any particular resource, any one particular resource, or even a lack of just financing alone by itself. Financing requires systems too, right? In order for money to get from one place to another, like something has to happen. And so I see it as like acknowledging that it's a state that's of a system that was designed to be one thing and is broken down in this particular situation. And then the question is, how do you improve that state? And recognizing that you probably don't know the answer to that. And like, I think that's so just to put a fine point on it. When I, when I started this work like 15 years ago, maybe 20 years ago, the mantra was, we know what to do, we just have to do it, right? Scientists love talking about like that, right? Like, we have the answers, we just have to implement the answers. And I tend to be suspicious when we say that. If we think we know the answers and it's not solving them, maybe we're asking the wrong question. Like there's another question, there's something else happening. I like to say that, like, when I first was around my front health center, this girl was dying of malaria, and there were 60,000 articles written on malaria since then, right? All of them with the claim framed as, we're here to help solve the malaria problem, right? This is like, I'm talking about Google Scholar. It's actually been like 100,000. And it's like, well, are they there to help solve the malaria problem? Because like, are they informed by the actual problem or not? Some of them are, some of them are not. So, so the way that I see it is we need a way of learning, right? Like we need to both address the system of healthcare and a way to learn from that. And so for us, health system strengthening means, yeah, it is in fact all of the above. It is 100%. It is, yes, there are financial limitations. Yes, there's supply chain issues. Yes, there's a personnel issue. Yes, there's an infrastructure issue. And if we don't address all of those, then we really will not see the other programs work as well, right? So we do all of that health system strengthening in accordance with the Madagascar policy. It's like and we research it, right? We collect information. We have 600 indicators in our mounting and evaluation system. We have dashboards, and the dashboards will say if there's a stock out or how many vaccines were distributed. It'll also have like maps of where people are, who's getting care and who's not getting care. We actually have dashboards now that provide infectious disease forecasts, nowcast and forecasts, to estimate what the burden is in the population based on the distribution that we're seeing. And it's accounting for geographic distances and limitations of what you're able to identify, and et cetera. So for us, it's like a lot of learning and recognize that, things may not go as well as we think, and which happens all the time, right? So supply chain is one of the big ones, but there's content. So some things end up working pretty well, and some things are much harder, and then some things are just like they crush you. For example, cyclones. Climate change has been a big issue. So we've had these terrible Madagascar, the region of Madagascar where Pivot works, has been struck by really devastating cyclones where the impact have been lasting. I mean, the roads that we use, that an ambulance would need to use, or something to transport a patient from a community to a health center, those roads are even more washed out in many cases than they were like 8 years ago. And that's just from a cyclone coming in and then destroying the health centers, destroying other infrastructure, destroying the schools, and destroying roads that get washed out. So, and then destroying crops and creating famine. So there are things like that are part of the system that ultimately results in whether people get sick and whether care can be provided. And we track that and we collect the information on that, and then we try to build it stronger and better or improve, address the issues that we see.
So the you mentioned these like 600 different things and these dashboards, and it seems like that is a better I forget what word you used, but it made me think of granularity. But like the the amount of things that you're tracking now and monitoring, you're able to see the system for what it is better than if you were just looking at the 5-year-old under 5-year-old mortality rate. And so
Right.
all of the things that you're able to track now, you're actually, it sounds like you're actually able to see whether it's 600 or a subset of those, a bunch of different data points and how well they're doing, and track those out into the future, which gives you more information and more ability to do good than just looking at a singular number, whether it's, maternal rates or 5-year-old rates or infant mortality. Is that, do you think that's a better way to look at things from that system's perspective, with a ton of data and dashboards and recognizing all of the different things that go into
Yeah, the
the
how
health
to.
ecosystem?
I mean, I see them as like, to be honest, so there's definitely a school of thought that's like measuring under five mortality is just like it moves too slowly, it can't inform decisions, etc. My view is I actually see that work that longitudinal cohort as sort of the core scaffolding or infrastructure of a lot of other things. So it's like we don't want to know merely how to improve programs that aren't reducing mortality.
Right.
Right? Like there has to be even if it's like mental, like it's even if it's about a North Star, recognizing that like we don't want to take for granted that things are having an impact. Like I don't take those for granted. I like and it is important. So for example, community we have lots of data from community health workers on they have our community health workers have smartphones. They use a smartphone to do the differential diagnosis for the patients. The data are stored. That data get logged into dashboards. That will tell us if they're at least treating for what if they are able to get the diagnosis, if they did have a stock out or didn't have a stock out, if they're able to treat them for what the diagnosis was, and so we can see improvements along those lines. But if that's not ultimately translating to better health outcomes, um, then we want to know. And I'll let me make one other twist to that. Which is exactly what we found. So like after the first 4 or 6 years, we weren't seeing a big change in under five mortality. We weren't sure why. So then we did this big geographic study where where Falanai Hantamalala, a health geographer, mapped out her and Andres Garcitorena, sort of a disease ecologist. They mapped out every footpath in the district, 20,000 kilometers of footpaths, right? Identified every structure, about 100,000 individual structures, including people's homes, um, and combined that with all of our medical records. At the time, that was about 350,000 medical records that we had, and geolocated every patient. So medical record has a geography, so now we know where they. And then we mapped out where they're coming from, and it turned out we didn't know this. A doctor didn't tell us this. It turned out that 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 we were having a really big impact on people who lived within 5 kilometers of the health system, and almost negligible impact on people who live more than 5 kilometers outside of from a primary care center. Sorry, not. So everyone knows there's that people closer that there are geographic barriers that they exist and that it does matter. Proximity matters. Like no one doesn't know that, but we didn't know how extreme that was. So it was a big drop off. Folks who lived near the primary care health center after it was strengthened, after provide these services, those folks were going to the healthcare center like 3 or 4 times a year. And that's pretty good. You don't need more than that, right? But the folks who are living 5 kilometers, which they were coming like once every 2 years, that's a huge difference for life-saving care. And so that led to programs to do community health work differently. So then the community health workers are starting to knock on doors, and they were rounding at the household level. So they would literally go to every household once a month, check in how the patients were, and then there we saw a much bigger increase on treatment diagnosis of known illnesses without seeing a major decrease in the treatment from primary care centers. So it's like, so those are examples where you're feeding off each other. You're seeing population level impacts on mortality. You're also getting information from the population from other kinds of data sources, geographic information systems and other stuff, and then combining that with patient records to get a picture, a complete with those indicators, a complete picture, a more complete picture of what's happening.
So
So I think you combine them all. They're all good. I wouldn't say the one's more important than the other. They're kind of like, I see them all as essential.
yeah. But so there's, I'd love to ask you a few more questions, but I also want to be mindful of your time. Are we okay to go a little longer?
Yeah, sure.
Okay. So I'm curious, just thinking about kind of that frame of proximity to care, where you get further out and you maybe have less frequent care. Are there also systems that still need to be built out so that the proximity or time to care is reduced?
Yeah. Yes. So, I mean, this issue of time to care and how community health workers work is a huge one. For one, this concept of like what we call enhanced community health, that's like more expensive, obviously, right? You have to. So to give you a sense of how challenging the situation is, the arrangement that we made in with the Madagascar government is to pilot a program where the community health workers are getting paid a minimum wage. So it's a salary, it's a job, right? You're paid, that minimum wage is about $60 per month, right? So it's probably more than a teacher would get, honestly, in these remote areas. So it's not nothing, it's not much. Even in Madagascar, it's not much, but it's an actual salary. But the Madagascar government can't afford that. It doesn't have the resources for that. And so there's like two minds of that. One is, well, that's okay. Like it'll eventually get there, like, and, it's relatively cost effective. Um, it would increase, for example, we've estimated that it would cost another $2 to $3 per capita to have that version of community health. That doesn't sound like that much. But it is for the Madagascar government. So realistically, they want to pay them less, have it be a part-time job. And so then the question is, okay, is it possible to be able to support community health workers who are doing more remote work, but might not be, who are so remote that not only is the enhanced community health hard to pay for, but even their supervision is much harder to get, right? Paying for supervisors. So as just one example, one thing that we're interested in not one thing that we have a small grant to do starting this summer is to see if a chatbot will help, right? So we're gonna if community health workers could have an actual on their mobile phone they normally use access to a chatbot that would serve some of the role of what a human supervisor might do. So they could ask them questions when the supervisor can't come, like, but every 2 or 3 months because it's so remote. And will that help them? Will they find that useful? Like, is that so? Things like that, are among the things we're exploring. But the Madagascar government says, the most that it feels comfortable compensating community health workers in the region is about equivalent to about $12 per month.
Wow.
So, which isn't nothing. And so we have a partnership with them. So we've gone from 200 community health workers to now 1,700 community health workers in the region. And we're doing the recruitment, the training, the compensation, but it's not the same as doing the $60 a month. So it's what are the systems of support that we can build up and strengthen that the government sees as on the path towards what it might be able to sustain over the long term. I don't know if that
So,
answers your question, but
well, it leads me to another question or set of questions about how these health systems get set up and how they're funded.
yeah.
And thinking about the role of different global organizations and the country, uh, whatever respective country where global health work is happening, and then also like the role of major philanthropic investment, and then also the role of the U.S. federal government, U.S. aid, and how that's I guess to make a coherent question, what has that looked like in setting
Yeah.
up the system in Madagascar, and what do you see? How do you see that changing over the next few years?
Yeah. Okay. So, um, I don't know how to answer this in a short way, so I'll do my best, right? So, well, 25 years ago, uh, the the concept of global health as we know it now didn't exist, right? HIV was a pandemic that was like taking over African countries. There are countries like Botswana where 30% of the population, had HIV, adult population with HIV. It was like truly decimating uh, the continent, and it, of course, also outside of Africa, but especially in Africa. And that was the moment when, and it was at a time of of actually unprecedented financial wealth, right? Like there was a tech boom, and like Microsoft happened, and among other tech companies. And there was that was at that point in time there was a commitment to address the HIV crisis, because in fact HIV drugs weren't as expensive to produce as the price tag was, and so it was solvable in principle. You could produce generically ARVs for a few $100s a year, not $10,000 a year. Um, so. So HIV was in theory something that could be addressed, and finally people were like, let's do it. The global community said, okay, we're going to take this on. We're not going to just ignore it. And from that you had this huge wave of like the Millennium Development Goals, the Global Fund to fight HIV, TB, and malaria, and what is basically amounts to the Gates Foundation was created, and what is basically amounts to the modern global health movement. And that has been largely highly effective, right? Like I think I don't know the numbers off the top of my head, but I would say something like um, for example, the life expectancy of a person in Botswana went from like 40 years in like the year 2000 to like 65 today, right? As just an example. You can quote me. That's about right. I'm just trying to recall them, but it's hugely effective. HIV is care that most countries you can, and so the system has been built around that. And then from there, people learned, oh, there's other illnesses that are just as prevalent and killing just as many people, like malaria, and it's probably having a comparable impact on economic development that we're just not even recognized because it's so endemic, right? As opposed to HIV, which sort of shocked the world. And it's also very inexpensive to treat. And if we can build systems to deliver HIV, why can't we build systems to treat malaria? And by the way, don't we need the same systems to do both? You need people. And so there became this concept of like doing healthcare, and and so just to give you a sense of scale of cost effectiveness, in the US we spend about $20,000 per year on healthcare. In Madagascar, they spend about $25 per year on healthcare. $25. Now that's too low. In a country like Rwanda, depending on, it might be $150 per capita, right? So this like huge global effort to address like really the most dangerous threats to the world at the time. We're talking about $50 per capita going into the healthcare systems from international. So this is small, right? This is a small portion. This ain't Medicaid, or Medicare for that matter. And so the effect has been these big, and for that matter, malaria incidences had dropped significantly over the last 20 years. So we see all these successes. So I think the meta story around the global health movement it's been really important, right? It's like affected, it has genuinely had an impact on the world. And we live in a different world today than we would have 25 years ago, thanks to all these initiatives. I'm like, there's a lot more than them, but I think the Gates Foundation is a good one on that particular topic to mention. Gavi with the Vaccine Alliance is another one that Gates supports. I'm not a huge fan of the Gates. I'm not in love with the Gates Foundation or anything, but like they're like an actor to point them out as an example. At the same time, like, sorry, this is a really long way of saying all this, but like, yeah, like there's lots of programs from USAID that I didn't think were particularly strong. You know, like we had words for them. Like we refer to like the consultants around as the Beltway bandits, right? You know, like not everyone in these institutions is addressing frontline issues, right? There's like whatever you want to call it, below bureaucracy, all that, non-trivial, totally serious. You know, like some money doesn't go to where it's supposed to go, and there's waste, like true waste. So to me, it's like, wow, those are two things can exist at once, right? Like even in a bloated system with lots of bureaucracy, really important things happened. Um, and so I'm very worried for like Madagascar. So USAID's pulled $100 million a year from Madagascar. That's a quarter of its budget. It's going to go from $20 per capita to 20 to $25 per capita to $15 to $20 per capita. It has a $12 million gap in its funding for malaria treatment, obviously treatable illness. The country, like really hard decisions are it has to face fundamental constraints in how it does work. So I'm worried. There's no one who does this work who isn't worried. I mean, even on the data front, like USAID pays for that demographic health. So they think the surveys I was talking about mortality, the only reason Madagascar knows it's under 5 mortality is from like things like USAID funded household surveys they do nationally, you know? So like data is important. That's a pretty high return on investment, like not the, and very, actually its health information system is highly funded by USAID. All the data that I mentioned that it collects also nationally. So it hurts. So the system is in pain, and it's definitely absolutely gonna hurt. The I'm like just slightly less pessimistic than everybody else, and the reason I'm less pessimistic than everyone else is because we've demonstrated, I'm saying this very collectively, that these programs matter. You know, lives can be saved. Lives like unnecessary suffering, unnecessary death, that actually can be unnecessary, and these programs can actually work. And it's like we're an example. I think Pivot is an example of an organization that is showing those kinds of results, but all we're doing is implementing the policies and programs and that have been advocated for 2 decades. So like that's 90% of what we're doing is helping the government actually do what the policy recommendations have been. So yes, those things can work. I think that reality is not going to go away, and I don't think the world is going to be poorer. I should put it another way: the inequality is not going to solve itself for the next 10 or 20 years. So there'll be a lot of wealth. It'll be growing wealth, and as if the problems are there, I do believe that people will show up. Like ultimately, really know what to make of the current trajectory towards isolationism, and some of it might even be understandable to some degree. But somehow there's just to me like the basic reality of what the stakes are and what the actual potential to address these issues to me seems like it'll per- um, it won't vanish.
Yeah. Well, I wonder if I could ask you one last question, just for people that are interested in working in global health, maybe college students. What advice would you give them um, in their careers, or just looking at global health as a profession right now?
Yeah. Geez, I feel like if you asked me that 2 years ago, it would be different than that. I feel like my advice a year or two ago would have been just follow your no do what you think is literally do what you think is right. Like follow the research, the questions, the things and if you do that, you will be ahead of everything else, right? That'll be the way to be out in front. So I feel like all the opportunities that I got were opportunities that surprised me and I even fell into. Like I have a background in economics and ecology. That's not going to make me a Madagascar healthcare provider, not obviously, right? But in fact, like so I didn't plan that. I didn't plan to be a professor at Harvard, right? Like those aren't plans. Those were I was doing a certain kind of work, and by the time that I had a certain set of skills, there were people who wanted to pay for those skills to be put to work. And so a big part of my core belief is do the stuff that you believe you want to do, that you think is the right thing to do, and that'll always be more valuable than the alternative, right? But I do think now one needs to be tactical, and also like if you don't need a lot, like if you can survive on ramen noodles, then you can afford you don't have to worry about losing your. I mean, you have to worry less about losing your job, right? And worry less about like what the return on investment is to spend a couple years living in somewhere where you're there to learn. Like I feel like I spent some time, living internationally, and mostly learning and not being very helpful. But that's okay. So I think if you can like lower what your needs are and honor what you think you want to do is right, then there's a lot of space in between to meet that, you know? That's my general advice. I do think that like for the moment, like it's hard to find global health jobs, you know, um, and there's an abundance of supply of laborers who work in that field who are looking for jobs. There's a lot of competition. So I don't know what I would say about being positioning yourself for a new job, but I would say the fundamentals of like educating yourself, understanding things deeply, like that's just not going to go away. You know, acquiring useful skills, you know, and things that interest you.
Yeah. Well, Matt, thank you so much for taking the time. I really appreciate you sharing your insights, and I hope we can have another conversation down the road.
Thank you. It's a pleasure.